Hello everyone, Dr. Abraham here. So this is our part 3. I welcome you again once again. So today we shall look at primary and secondary skin lesions in dermatology, distribution of disease, and then disease configuration. So in this part, I dedicate it to my wife, Esther. Greetings, Esther. I know you're not watching, but this is for you. So we shall dive in right away with an introduction. So usually in dermatology, when you're looking at skin rashes and lesions, we want to know what do they look like and the significance, what can you pick from what you see? And this is very key when you're making diagnosis in dermatology. So the objective of this lecture is that we have to learn today how to distinguish or to know that this is a primary skin lesion or this is a secondary skin lesion. And then you want to give a description of each and maybe give list a few conditions that can give such a skin lesion. So when you go to primary skin lesions, these ones are the initial lesions that characterize a particular disease or disease process. So, and these are the direct changes in the skin that disease usually brings to the body. So this is very key, is that because if you're able to identify the primary skin lesion, you'll be able to actually get the majority of the information about that skin condition, and you are able to actually, in some conditions, get a diagnosis right from the primary skin lesion. And then the significance is that we have so many disease conditions on the skin, so many disorders, and their early diagnosis is very critical. So this can only be achieved if you are able to identify a primary skin lesion. So right away, we start with the first one. The first one, we call it a macule. And when you see this word macule, just remember something that is very flat. You cannot palpate it, and it is basically skin in the skin, changing skin color. And most importantly, it has to be less than 1 centimeter in diameter. And the examples of these include freckles, vitiligo. It can give you this color change on the skin that you cannot actually palpate and feel. When you touch the skin is very smooth, but your eyes are able to visualize and see that there is a color change. That if it is less than 1 centimeter, we call that a macule. Then when you go to a patch is just a bigger macule, still very flat, non-palpable, and this one only changes in the diameter. So if it's less than 1 centimeter in diameter, it becomes a patch. So we see this in vitiligo, where we shall get maybe hypopigmented patches, or we can see this in what we call cafe ole macules seen in neurofibromatosis. Even melasma gives hyperpigmented patches on the face, and dermomelanoma cytosis, or what we call the Mongolian spot. This one is very common. I think everyone has seen this. And this is the patch that we are talking about there. Then we have what we call a papule. A papule is an elevated circumscribed skin lesion which has a diameter of less than 1 centimeter. So in this case, when you palpate, you can feel the elevation that this skin lesion is actually above the skin. So these papules can also have other things, other secondary changes that can occur to them. They can have a scale on top, they can have a crust on top, they can have an erosion on top, they can also take on different shapes and topography on top. So you can find some papules which are flat-topped. When they are flat-topped, we call them lichenoid. You can find some that are dome-shaped. You can find some that are umbilicated with a dimple at the center. And you can find some that are verrucous with a rough surface on top. So those are the papules. So when you're describing a papule, you'll say that in this case, maybe I see a flat-topped papule, or you can simply see a lichenoid papule, or you can say a verrucous papule, you can say maybe a filiform papule. So, and in this picture, so this is what a papule will look like. Then, if so many papules come together or coalesce, they form what you call a plaque. So in this case, you have a skin lesion that's elevated and palpable, well circumscribed, and a diameter of more than 1 centimeter in diameter. So in this case, this elevation it goes above, or there's an increased thickness of the upper layer of the skin that we saw earlier, the epidermis. It may be due to maybe the cells in the epidermis are more than the normal, or even the cells within the dermis maybe are more than normal, or even have just increased fluid in between these cells, what we call edema, so causing that elevation giving you a plaque. So it can also get secondary changes, which we shall see later, which can either be a scale or a crust, and occasionally a plaque is palpable, but not elevated. So you can sometimes just actually when it is, how can I say, when it is in deeper layer of the skin, like in morphia, although this is not for this level, but in morphia, we can actually get a plaque that is not elevated above the skin, but when you palpate, you can feel something hard within the skin that also remains a plaque. Example of conditions that where we see plaques, even we can include psoriasis, lichen simplex chronicus, sarcoidosis, and the rest. So then the next primary lesion, we call it a nodule, and then in this case, this is like a papule that we've seen earlier, but in this case, it has a deeper component, and its diameter can be above 1 centimeter. So in this case, when you touch and palpate and feel, you'll find that there's some bigger part of this lesion that is below the skin. That is what we call the deeper component, and that will give you a nodule. So in some cases, you can have what we call a nodulopapular rash, whereby on top it looks like a papule, but it has a deeper component. So that is the description that can give in such a case. So in this case, nodules usually involve the dermis and or the subcutaneous tissue, and you may find that the greatest portion of them is actually beneath the skin. Then the next primary lesion, we call it a wheal, and wheal is one of the elusive primary skin lesion in that for it is transient, it is there for a short period of time. So someone can have it at home. As they reach the hospital, it has disappeared. So in definition, this word is very key. It is a transient elevation of the skin, and it is usually due to dermoedema, and often it can be pale at the center and having an erythematous rim. So I think you've seen this before. This and that before, so that is what we call a wheal. Then the subsequent primary skin lesion, we call them vesicles, and then in vesicles you have something that is elevated above the skin, well circumscribed, less than a centimeter in diameter, but in this case it is filled with a fluid. So when you have such arrangement, then you say that this is a vesicle. So depending on the content of this vesicle, it can either be serous fluid, it can be blood. So you can see maybe it is a hemorrhagic vesicle if it has blood inside, or it is serous if it is just has serum inside. And in some cases, they can even become pustular, umbricated, or even develop into erosions, as we are going to see later on. So if you find a very big vesicle, in this case, it will become a bullae. In this case, if you get a circumscribed elevated lesion, which is more than 1 centimeter in diameter, and it is filled with fluid or serous or blood, provided the diameter is bigger than 1 centimeter, it becomes a bullae. And then in this picture, this is what we are talking about. All this swelling that you see here is a bullae. And the next one, we call it a pustule. Pustule comes from pus or purulent. So in this case, if you get an elevated circumscribed lesion, usually less than 1 centimeter in diameter, and from onset, it actually just has purulent fluid, we call that a pustule, as you can see in this picture. And when you press and rupture it, it will just give you pus. So we proceed to the secondary skin lesions. And if you are to define secondary skin lesions, you look at these lesions as the changes that can occur to the primary skin lesions, either due to modification by the patient as they manipulate the lesions, or due to progression of the disease. And in this case, you're looking at both either internal processes or external processes. So if it is external process, meaning that it is the person that tried to modify the primary skin lesion, or a superimposed infection, or even a healing process if it is internal, and that becomes the secondary skin lesion. Then these lesions usually, as we've mentioned earlier, they can arise from primary skin lesions or due to complication of the condition. The first one, we call it a crust. And then a crust is just dried serum or blood or pus that is over the surface of the skin. So depending on the type of the crust, it can also give the idea of what was there before. So if the crust is yellow, that means that previously it was pus. If the crust is a little bit black and white, it looked like that initially there was even blood. So depending on the causative agent of the primary lesion, then you know what type of crust you would form. And then the crust is also called scab in other literature. Then when you go to the scale, scale in medical term just simply means hyperkeratosis. Remember in part 1, we looked at the stratum corneum. So if you have that stratum corneum being too much, more than normal, and then failing to go off in the normal way, but still hanging around, that is what we call hyperkeratosis, and that gives rise to the English name that we call scales. So in this case, it can be due to either proliferation or delayed desquamation of the stratum corneum, and these are the scales that you are seeing in this case, in these patients with the ichthyosis. Those are the scales. Then there's the subsequent skin lesion, we call it a fissure. This one just simply means a linear cleft in the skin, and often it is very, very, very painful. And usually it comes from drying of the skin. So when the skin dries and it's not, losing the upper layers nicely, that dryness causes the skin to crack, because the upper layers are very tough and taut, but then the underlying skin is soft and tender and fragile. So because of that, then you get these cracks that we call fissure. Then the next one is excoriation. Excoriation, also called scratch marks, comes from your external injuries to manipulate the lesion by either scratching, grabbing, or anything like that. So you lose the upper part of the skin, we call the epidermis, and then you get up, you end up with an erosion. So depending on the nature of the excoriation or how you induce the secondary lesion, the excoriation are either punctate or linear. Linear is just if you just have a line of a scratch mark like this. Then punctate if we just have just areas of epidermis that are pinpoint like that shading I've done. So that will be linear. Then if it is in that arrangement, it will be punctate. So linear, punctate, linear, punctate. Then erosion just simply means loss of the epidermis, and in this case, we see it in conditions like 10, you have now a loss of the epidermis, or someone falls or gets an accident, and then they get this erosion. So when you lose an epidermis, the upper part of your skin, we call that an erosion. But then an ulcer is deeper than the erosion, so you lose even part of the dermis or even the subcutaneous tissue. If you see that the epidermis has gone, part of the dermis has gone, or subcutaneous tissue, that one becomes an ulcer. And when describing an ulcer, we want you to look at, you describe for us the floor, the roof, the margin, the border, and the surrounding skin. So you have to give a description. How is the floor? How is the roof? How is the border? How is the margin? And how is the surrounding skin of that ulcer? Then an infarct usually is just ischemic tissue. For example, if someone gets the gangrene due to maybe peripheral arterial disease, so they will get something like that. This is described as an infarct. Then atrophy just simply means thinning. So when the skin thins, the atrophy can either be in the upper layer of the skin, the epidermis, we call it dermal atrophy. If it is the epidermis, we say it is epidermal atrophy. It's in the dermis, dermal atrophy. It is in the subcutaneous layer, subcutaneous atrophy, or lipoatrophy. So in this case, this is the epidermal atrophy, just the epidermis that is thin. Then if it is the dermal atrophy, you know all stretch marks, that is dermal atrophy. And you can also get subcutaneous atrophy, like when someone has loss of lipids, and we see this in lupus paniculatus, and someone will look like this. Then lichenification just means thickening. In this case, we have accentuation of the natural lines, those are the creases on the skin, and this simply reflects acanthosis, this just thickening of the epidermis. And the most common trigger is you rubbing or scratching the skin continuously. You end up with this lichenification. So someone is asking here, what should we do to learn more in dermatology? And the answer is simple. Just subscribe to this channel, like the content that we create, comment, share with your friends, and let us learn dermatology together. So when you go to palpation of skin lesions as you are examining, we've talked about that in the previous video in part 2. So usually you want to feel, is the lesion soft or is it firm? So, and that gives a diagnosis, and these are the examples. Is it hard, like in carcinosis cutis? Is it firm, like in dermatofibroma, or is it soft in an intradermal nevus? So is it compressible? When you press, does it, are you able to reduce its size after compression, or is it is not compressible? And if it is compressible, that means that the content is more like fluid. If it's not compressible, the content is solid. Is it painful, or is it not? Is it blanchable, meaning that when you press, it becomes it loses the readiness, and then when you remove your hand, the readiness comes back. So if it is blanchable, then it may be due to vasodilatation. That means that when you occlude the vessels, the redness goes away. But if it is non-blanchable, that means that it is actually bleeding under the skin, and you cannot take that away. So even when you press, there's no change in the color. So is it rough, or is it smooth? Because we see, for example, in scarlet fever, when you palpate the skin, it has a sandpaper feel, so that is rough. Then is it mobile versus fixed? So mobile meaning that when you touch, it is able to move, or is it fixed on the underlying tissues, like in cancers? Is it a dermal? If it is within the dermal, you can move it, or is it within the subcutaneous fat that you cannot palpate below it? And then the temperature. Is the temperature normal or warm compared to the surrounding area? Are there any other features like thrills? Is it pulsatile, like the vesicular malformations? If you have vesicular malformation, you need to comment that are you able to pick thrills or pulses. So then we know that is it arterial or even venous. So when you go to disease configuration and distribution, this is very important in dermatology, because the configuration and distribution of disease also gives us a clue on diagnosis. So configuration just simply means how is the skin lesion arranged on the skin. Remember this word. Configuration is arrangement of skin lesions on the skin. So how is the skin, how is this lesion arranged on the skin? So we have different configuration patterns. And the first one is annular, meaning that it is round, like the way you see this normal tinea corporis, the way you see granuloma annulare. So these things, the arrangement on the skin is that they will give you that annular appearance. Then we have conditions that give you serpiginous pattern. For example, the cutaneous larva migrans. I think this one we've seen it in Africa. We are in Africa, so we've seen this so many times. Or are the skin lesions clustered or grouped? For example, in the vesicles that we see in HSV infection, they are herpetiform, meaning that they are grouped or clustered in a particular area. Then is the skin lesion reticulate? Reticulate is like a net-like pattern. For example, in erythema ab igni, or even in levido reticularis. So this one is the reticulate pattern or configuration. Or is the skin lesions arranged in a linear configuration pattern, like in lines? For example, if I'm to give you an example of like things that follow brush code lines, those lines of development, so they follow a particular linear pattern, like things that follow a dermatome. So these are examples. For example, in this case, someone went outside, maybe exposed to did an outside job, then they got allergic contact dermatitis secondary to poison ivy. So you find that these lesions will follow the line where this person got contact to that plant. And we all know sporotrichosis at least. So we find that in this case, this is a linear configuration pattern, but in this case, it is following along the lymph node, giving rise to what we call the sporotrichoid pattern. So you have diseases that actually give rise to this pattern of what? Of distribution. I'll give an example. For example, if you get sporotrichosis, if you get cat scratch disease, all of them, they follow these lymph nodes. And then also we have other patterns. For example, herpes zoster will give you this dermatome, will be following along the dermatome, maybe C1, C2, C3, C what, and then that is dermatomal configuration pattern. And it can also be segmental, like in a particular section of your body. So for example, in neurofibromatosis, the segmental type, I think that is like neurofibromatosis 3. So it will give you that type of what? That type of arrangement. Then we have others, like for example, linea nigra follows a very straight line along just along your mid part of your body, along the abdomen. Then we have linear configuration patterns that are secondary to outside features. For example, Koebner phenomenon. So in this Koebner phenomenon, it simply means that you have a primary skin condition, for example, lichen planus, then you scratch your body along a particular line, and what happens is that these skin lesions usually come and form a line along this body scratch that you the person induced. That's what we call cognalization. Or okay. Then other things like brush code, I've mentioned brush code lines. So these are lines of development, like how the skin moves during embryology. Those are the lines the skin follows. So when you can get a disease condition that follows brush code lines. For example, lichen striatus. Another example would be bronchitis. Another example, we can have epidermal nevus and the rest. So configuration, I've talked about already brushcoid. We've talked about the dermal distribution pattern. We have talked about Koebner already, and trauma-induced inoculation, spot trichoid pattern, and all these others. We have already finished that. So when you go now to the distribution, so distribution patterns are different from configuration. So in distribution, you're looking at a patient as a whole. How do these skin lesions distribute anatomically on the patient's skin? So the key word here is anatomic distribution of the skin lesions. So you'll find that particular disease conditions, there's a way they love to map themselves on the skin. So in the distribution pattern, you can have disseminated, covering the entire body, versus localized, versus solitary. You can maybe have one rash somewhere, maybe one swelling somewhere, one nodule somewhere, one papule, one plaque somewhere. So that will be a solitary papule, a solitary plaque. Or localized, covering a particular region of your body, maybe the abdomen, localized to the abdomen, and disseminated all over the entire body, maybe sparing a few parts of your body. Then we can have a distribution which is unilateral versus bilateral, also called symmetrical. So unilateral is just on one half of the body, then bilateral on either half. So then you can have symmetrical versus asymmetrical, sun exposed versus sun protected. So you can find someone with a rash, maybe for example in discolored lupus erythematosus, that one loves the sun exposed area. So you find it on the head and neck, and maybe the hands, because those are sun exposed. Then you find other disease conditions which actually prefer the sun protected areas. So when you look at a disease, or when you look at a patient, you need to know how is this condition distributed on the patient anatomically. That is the keyword. Then you find some conditions preferring the fracture areas, others preferring the extensor areas. For example, for fracture areas, we have things like atopic dermatitis, maybe in around the adolescents and adults, it loves the fractures, whereas psoriasis loves the extensors around the knees, around the elbows, and the back of at the back of the at the lower back. Then we have intertriginous, intertriginous meaning just in the body folds. For example, inverse psoriasis, seborrheic dermatitis, those ones are like in inverse lichen planus. Those ones love the intragenous areas that includes maybe below the breast, in the axilla, in the gluteal folds. Those are intertriginous areas. Then we have conditions that love the acro areas, the extremities of the body, like the hands, the feet, the ears, the nose. Like for example, the acrodermatitis. The acrodermatitis pustules, like the one in infants, loves the hands. Gynecomastia loves the hands. All those love the acro areas. Then you can have a palmoplantar distribution. For example, in palmoplantar keratodermas, the distribution in that case or the location of the disease anatomically will be the palms and soles. That gives rise to the palmoplantar distribution. Then seborrheic regions, these are the areas that have a lot of sebaceous glands. So we have disease conditions that have a distribution pattern that we call seborrheic in nature. For example, when you look at acne vulgaris, when you look at things like Pittosporum folliculitis, when you look at things like Darius disease, all those ones have a seborrheic distribution. Then we have what we call peri-orofacial. So peri-orofacial, for example, in steroid-induced acne, so the rashes, you find them all around the mouth, all around the mouth. That is what we call peri-orofacial. Then we can have disease conditions that love the mucosa. So you'll find that all lichen planus is only in the mouth or even in the genitalia, in the esophagus, only in the mucosa. So if the distribution in that case anatomically will be mucosal distribution. And then another important factor to consider here is that the linear, the one we saw as configuration, is also considered a distribution pattern. So that one should not bring confusion. So of all the distribution patterns of disease, one of them is also a configuration pattern, meaning that you can use the word linear to describe the distribution of disease as well as its configuration. So that is a very, very important point to note, that when it comes to linear, we use it for both distribution and configuration. So here I was trying to show you what we mean by cobnalization or the isometric response. So in this case, we say that initially you have a skin condition that like lichen planus in this picture that we see. But then someone scratches on the body or gets a wound or a trauma. So what happens is that the disease comes and follows that line of trauma. And in this case, this is where the patient scratched first and the rash follows that line. So that's what we call Kobna phenomenon. And we have examples of conditions that usually love to show this type of arrangement. Psoriasis, vitiligo, lichen planus, lichen nitidus, cutaneous small vessel vasculitis, Still's disease. So all this give Kobna phenomenon. Thank you very much, my dear followers and viewers. I hope you enjoyed this video. I still remain Dr. Abraham from ENT Dermatology Specialist Uganda. Please, we encourage you to follow, subscribe, comment, and share with your friends this medical education. See you in the next part.